I want you to take a second and just imagine something.
Okay.
Imagine holding your breath right now.
Like right this second.
Exactly. Hold it. And then imagine trying to walk up a flight of stairs.
Oh, wow. Yeah.
Think about that rising panic, that relentless, impossible feeling of air hunger.
It's terrifying just thinking about it.
Right. But for patients living with interstitial lung diseases, or ILDs, and specifically a condition called idiopathic pulmonary fibrosis, that is not a thought experiment.
No, it's not.
That is their daily reality.
It is a profoundly sobering clinical reality. And it really underscores why the material we're diving into today is so critical.
Yeah.
We're looking at a highly comprehensive medical review published in the American Journal of Radiology, the AJR.
The focus is on the quantification of interstitial lung diseases.
Spot on.
And the mission of this deep dive into the source material is to explore what I would call a massive paradigm shift happening in medicine right now.
Oh, absolute massive.
We're going to look at how cutting-edge artificial intelligence and something called Quantitative CT, or QCT, are completely revolutionizing how doctors see and measure these incurable lung diseases.
We are talking about a monumental leap here, moving from, subjective human guesswork to highly precise, pixel-by-pixel machine learning.
And look, even if you aren't a practicing radiologist or a pulmonologist, this still matters to you.
Oh, 100%.
Understanding how AI is successfully replacing the human eye to detect incredibly subtle, literal life-or-death patterns in medical data, it offers a massive aha moment.
It really is a window into the actual future of personalized medicine. I mean, we are seeing machines catch microscopic textures that the most highly trained human experts simply cannot physically perceive.
Okay, let's unpack this, because to really appreciate what the AI is accomplishing, we have to look at the human biology it's actually analyzing.
Right, the lungs themselves.
The sources describe ILDs as a diverse group of conditions that cause inflammation and varying degrees of fibrosis in the interstitial compartment of the lung.
Fibrosis meaning scarring.
Scarring, exactly.
Yeah.
The tissue gets thick, it gets stiff, and it physically destroys the lung's architecture and its ability to exchange gas.
And idiopathic pulmonary fibrosis, or IPF, is the most common and devastating form of this.
And it's insidious. Right?
Very. It usually shows up with an insidious onset. Patients slowly develop dyspnea, which is shortness of breath, and a persistent dry cough. And this often happens way before they realize anything is seriously wrong.
The truly agonizing part of the clinical context here is that fibrosing ILD is currently incurable.
Yeah, some forms of lung fibrosis just keep progressing relentlessly.
Now, there are 2 FDA-approved drugs available for treating pulmonary fibrosis.
Right, nintedanib and pirfenidone.
Yes, those 2. And these medications have been shown to slow the disease down, but they do not reverse the scarring.
And they certainly don't cure it.
So the massive clinical challenge for doctors, the real daily dilemma, is deciding when and how to initiate or change treatment.
And that decision relies entirely on accurately tracking the rate of the disease's progression. Which brings us to the old way of doing things.
The traditional visual assessment.
Historically, and even largely today in a lot of clinics, a radiologist looks at a high-resolution CT scan, an HRCT, and they visually estimate the extent of the fibrosis.
They're literally just looking at the scan and trying to gauge the damage.
To the nearest 5%, 10%, or sometimes even 25% increments.
I mean, they are essentially taking 2-dimensional slices of an image on a monitor and trying to perform a complex mental integration of a 3D volume.
It's nearly impossible to do accurately. The sources provide a rather shocking statistic on how effective that actually is in practice.
Because visual assessment is incredibly subjective.
Highly subjective. There was a major clinical research network study called the IPFNet trials.
Right.
When researchers looked at the agreement between 2 human observers trying to score the disease extent on the exact same scans, it was rated as a poor 0.3 on the weighted Kappa scale.
Let's break that metric down for a second, because a 0.3 sounds incredibly low.
It is incredibly low. The weighted Kappa scale is a statistical way to measure the level of agreement between 2 raters, factoring in the probability that they might just be agreeing by pure chance.
Okay, so what's a good score?
A score of 1.0 means perfect, absolute agreement between the 2 doctors.
And a 0.
A 0 means no agreement whatsoever beyond random chance.
Wow.
So a 0.3 means the human observers in this trial were wildly out of sync with each other.
Humans, no matter how much specialized medical training they have, are just not inherently designed to mentally calculate 3D volumes of complex overlapping textures.
Exactly. They are highly susceptible to both interreader and interreader variability.
Meaning one doctor looks at a scan on a Tuesday and estimates 15% fibrosis.
And another expert looks at the exact same scan in another hospital and sees 30%.
I want you to really think about the implications of that for a moment. Imagine it's you or your family member sitting in that examination room. Your critical, life-altering treatment plan, a plan involving heavy pharmacological therapy with significant side effects.
Very serious side effects.
Yeah, and it's relying on an eyeball estimate that another highly trained doctor down the hall might completely disagree with.
It is a terrifying bottleneck in patient care.
If we connect this to the bigger picture, the major regulatory bodies are fully recognizing this limitation.
They have to. The FDA is actively pushing for clinical trials in pulmonary fibrosis to shift their focus. They want to see outcomes that measure how a patient actually feels, functions, and survives.
Feels, functions, and survives.
Exactly. But to get those patient-centered outcomes, to know if a trial drug is truly working to extend survival over a few months, we desperately need objective imaging biomarkers.
The sources define imaging biomarkers as quantifiable features of medical images. We need the data to be exact, not estimated.
No more guessing to the nearest 25%.
Right. And I was reading about the first attempts to solve this with computers, which the review touches on. Let's call it Generation 1.
Early computer methods.
Yeah, they used attenuation-based metrics.
Yes. Those early systems relied on the CT lung attenuation histogram. The computer would analyze the scan and calculate exactly how many lung voxels, which are essentially 3D pixels, fell between -600 and -250 Hounsfield units.
Because that specific density range is where fibrosis usually sits on a CT scan.
Precisely.
It seems like a logical first step. You just ask the computer to count the dense spots.
And the text notes, it worked to a degree. It correlated moderately well with pulmonary function tests.
But it had a massive glaring blind spot. It just counted the voxels.
It completely ignored where those voxels actually lived in the lung or how they were structurally arranged.
Think of it like analyzing a novel. It's like a computer telling you a book has exactly 400 words that indicate sadness, but it gives you absolutely no idea if those words are grouped together in one tragic, devastating chapter.
Or if they are spread randomly throughout a lighthearted comedy.
Exactly. You lose the structural context entirely. You just have a bucket of pixels.
Which is not enough for complex diseases.
Here's where it gets really interesting. Generation 2 is texture-based quantitative CT, utilizing modern deep learning algorithms.
AI doesn't just count the pixels in a certain density bucket anymore. It actually understands spatial arrangement.
It understands the microarchitecture of the texture.
The visual representations of this in the source material are genuinely striking. You start with a patient's HRCT scan, which to the naked eye just looks like a static grayscale cross-section of the chest.
Right.
The deep learning AI analyzes it and generates a 3D overlay with vivid, highly specific colors to map the exact pathology of the disease.
And the colors correspond to different types of damage.
Exactly. It uses blue to highlight reticulation, which is a net-like scarring pattern in the tissue. It uses pink to flag honeycombing, which represents advanced destructive cysts in the lung. And it uses yellow to map out ground glass opacities, which can indicate inflammation or early fibrosis.
So it takes that grayscale guessing game we talked about earlier and transforms it into a hyper-precise, color-coded 3D map.
The power of that precision is staggering when you look at the clinical outcomes. We aren't guessing to the nearest 25% anymore, or hoping two doctors agree.
The QCT algorithms are so deeply sensitive that they can detect minuscule physiological changes over a very short period of time.
The research highlighted in the review shows that a mere 3.4 to 4% change in the quantitative extent of fibrosis over just 6 months can accurately predict a patient's progression-free survival.
That level of granularity, seeing a 3.5% shift in a 3D volume, is completely invisible to the human eye.
But the machine tracks it flawlessly.
We have to look at the clinical reality of AI today, because this is not just a theoretical tool sitting in a lab anymore. It is actively being tested against human experts and outperforming them.
The text highlights an incredible example called the SOPHIA algorithm.
SOPHIA stands for Systematic Objective Fibrotic Imaging Analysis.
The researchers trained SOPHIA to classify high-resolution CT patterns based on strict, multi-society guideline categories for diagnosis. They fed it massive amounts of data so it could learn exactly what these distinct disease patterns look like at a microscopic level.
Then they pitted it against the humans. They tested Sophia against the consensus of 91 specialist thoracic radiologists,
91 dedicated experts looking at the same scans.
and Sophia achieved expert-level accuracy. But the AI's probability score actually predicted patient mortality independently of traditional disease severity measures.
It saw something in the textual arrangement of those scans that meant life or death, even when the human visual estimates or standard lung function tests missed the severity entirely.
That unique ability to see beyond human capability is echoed in another deep learning system discussed in the review, known as the multiple instance learning, or MIL, algorithm.
Right. This specific system was tasked with diagnosing a very specific, often deadly pattern called usual interstitial pneumonia, or UIP.
The text mentioned how it stacked up against the human visual assessment for diagnosing histologic UIP.
It outperformed them by a significant margin. We measure diagnostic accuracy for these types of tests using an AUC curve, or area under the curve.
In simple terms, an AUC of 0.5 is basically a coin flip, and 1.0 is a perfect test that never makes a mistake.
Exactly. The human visual score managed an accuracy of 0.65 to 0.71.
Okay,
The MIL algorithm scored between 0.77 and 0.79.
that's a huge jump.
But the true clinical impact of that accuracy is the real story. Patients who were flagged by this AI as being UIP positive saw a significantly faster decline in their lung capacity.
I recall the exact numbers being quite stark.
Extremely stark. The AI-flagged patients showed a decline in forced vital capacity of 288 milliliters per year, compared to just 245 milliliters for those flagged negative.
So the AI is accurately identifying the patients who are in the most immediate, critical danger of rapid decline well before the humans can confidently make that call.
Yes.
That brings up one of the most mind-blowing anecdotes from the text, documented in Figure 3. It explores the concept of catching the invisible, preclinical disease.
This is fascinating.
Imagine a 79-year-old woman. She goes to the hospital and gets a routine CT scan just to check for internal injuries after suffering a physical trauma.
Right, she's not there for her lungs.
She has no pulmonary complaints whatsoever.
A human radiologist reviewing that trauma scan is looking for broken ribs or internal bleeding. They might easily miss a tiny asymptomatic abnormality in the lung tissue.
Or simply dismiss it as an artifact of the scan or normal age-related changes.
Exactly. But the researchers ran that exact scan through the QCT algorithm. The AI spots what it calls a preclinical interstitial lung abnormality.
It flags exactly 4.4% fibrosis in her lungs.
Keep in mind, this patient feels entirely fine. No cough, no shortness of breath, no symptoms.
And then, 29 months later, they scan her again. The AI shows that the fibrosis has quietly crept up to 8.4%.
The clinical significance of that case study is absolutely groundbreaking for preventative medicine.
QCT has the proven capability to identify deadly, progressive lung diseases in people with zero symptoms, potentially years before traditional diagnostic methods would ever trigger an alarm.
The data shows that an increase of just 0.58% in quantitative fibrosis over 5 years in individuals without known ILD is heavily associated with increased mortality.
0.5% over 5 years.
0.5%. It proves unequivocally that we can find and quantify clinical outcomes in preclinical cohorts with incredibly minimal amounts of fibrosis, using the exact same metrics we use in patients with established severe disease.
So what does this all mean for the future of lung analysis? It means we're moving way beyond just looking at the obvious scars. We're transitioning to analyzing the entire lung ecosystem as an interconnected unit.
The AI isn't just staring at the damaged tissue. It performs automated segmentation of the entire pulmonary anatomy.
It builds 3D surface-rendered segmentations that are incredibly complex.
It maps out the left and right lung lobes in different colors. It builds the complete 3D topological model of the tracheobronchial tree, the intricate network of airways.
And it segments out the entire pulmonary arterial vasculature, the blood vessels winding through the lungs.
When the AI looked at all of those different parts of the ecosystem together, it found something that completely shocked the medical researchers.
What's fascinating here is that the machine learning algorithms discovered that changes in the vessel-related structures are actually the strongest independent predictors of mortality in patients with fibrosing ILDs.
That's right.
The blood vessels are predicting mortality better than the scars themselves.
Yes. Even more than the severe honeycombing scars that radiologists have traditionally fixated on as the ultimate definitive bad sign.
That is wild.
Quantifying the pulmonary vessels and the perivascular fibrosis, the scarring immediately surrounding those vessels, improves outcome prediction beyond all the standard measures of disease severity.
It predicts patient survival and lung capacity decline at 12 months, better than looking at the volume of fibrosis alone.
The AI essentially taught us an entirely new way to understand the pathology and the progression of the disease.
That is just incredible. But it begs a really obvious question for you listening. If this AI is so vastly superior, if it catches invisible disease at 0.5%, maps 3D volumes flawlessly, and predicts mortality better than 91 dedicated experts, why isn't every radiologist in the world utilizing this software tomorrow morning?
It is the vital question of implementation. And the answer comes down to a combination of severe technical bottlenecks and deeply entrenched bureaucratic roadblocks.
Let's start with the technical side.
QCT algorithms are hypersensitive, which means the raw data you feed them has to be pristine and perfectly standardized across the board.
The sources outline some incredibly strict imaging protocols. You can't just throw any old CT scan from any random clinic into the algorithm and expect a magic result.
The technical requirements are rigid. The QCT requires non-contrast scans. They must be inspiratory scans, meaning the patient has to perfectly hold their breath at maximum inspiration so the lungs are fully inflated.
The physical slices the scanner takes have to be 1.5 millimeters or less in thickness.
And here is a massive technical hurdle for modern hospitals. Newer CT scanners frequently use something called iterative reconstruction, or IR.
Hospitals love IR because it is a great technology designed to reduce radiation noise and lower dose scans. It protects the patient from excess radiation.
It does, but IR actually introduces nonlinear effects on the underlying texture of the image. The software artificially smooths out the visual noise.
It essentially smooths out the image too much.
Right. It tricks the AI by aggressively messing with the microscopic texture that the deep learning algorithm fundamentally relies on to spot that 0.58% change.
Therefore, iterative reconstruction is actively not recommended for QCT analysis.
Furthermore, if you are doing longitudinal evaluation, meaning you are tracking a single patient over a period of years, it is absolutely critical that you acquire the baseline and follow-up scans using the exact same reconstruction technique.
And ideally on the exact same physical scanner.
Yes. If a patient uses a GE scanner on day 1 and a Siemens scanner 6 months later, the slight proprietary variations in their specific reconstruction algorithms could easily register as false disease progression by the AI.
That is a massive logistical nightmare for hospital networks and for patients who might move or change providers.
It is.
But the text mentions an even bigger bureaucratic hurdle holding this back, the FVC debate.
FVC stands for forced vital capacity.
It is a very common pulmonary function test, where a patient basically blows as hard and as long as they can into a tube to measure their total lung volume.
For decades, FVC has been viewed by the major regulatory bodies as the absolute gold standard clinical endpoint to measure whether a patient's disease is progressing or if a new trial drug is actually working.
The sources, however, argue quite forcefully that FVC is deeply flawed as a benchmark for this new era of medicine.
It is an inherently imperfect, noisy measure. FVC is highly dependent on the patient's physical effort on that specific day. It is dependent on the technician's coaching and encouragement during the test.
Most importantly, it is incredibly insensitive to subtle physiological changes in disease status.
Right. If a patient has a slight, localized increase in fibrosis, their overall FVC score might not drop at all initially. The healthy parts of the lung compensate.
Yet, despite FVC being an indirect and noisy measure of disease, these highly precise 3D QCT algorithms are often unfairly forced to prove they are superior or non-inferior to FVC before they can be fully adopted as primary endpoints in clinical trials.
It's like forcing a microscopic laser measuring tool to prove it is better than a stretchy, worn-out tape measure by making the laser mimic the tape measure's inherent flaws.
That is a great analogy.
It absolutely hinders the recognition of QCT's true value in the clinic. We have concrete data showing that quantitative imaging parameters are strong, independent predictors of survival, even in individuals who still have a perfectly preserved, normal FVC score.
The AI directly measures the microscopic lung structure. It does not wait for the structure to fail so badly that the patient literally cannot blow into a tube anymore.
Exactly.
Let's recap this incredible medical journey we've been on. We are looking at a field that is rapidly moving away from subjective, wildly varying human estimations of lung scarring.
An old, flawed system where doctors literally had to guess the volume of structural damage to the nearest 25%, often disagreeing with their own colleagues.
We are moving headfirst into an era of hyper-precise, color-coded 3D AI models. These deep learning algorithms can predict a patient's mortality based on microscopic textural changes and vascular patterns that the human eye cannot even perceive.
The transition from simple pixel counting to spatial deep learning has unlocked imaging biomarkers that don't just confirm a diagnosis, but actively predict the future trajectory of a human life, long before the symptoms ever manifest.
That leaves us with a fascinating final thought for you to mull over as we wrap up this deep dive. We've established that this technology is vastly superior to human visual assessment. We've seen it outperform a consensus of 91 specialist thoracic radiologists.
Which raises an incredibly profound question about the future of medical expertise.
Right.
If an AI is learning from the 91 top human experts today, and then quickly surpassing them to see microscopic textures and predictive vascular patterns that humans literally cannot perceive, how do we train the human experts of tomorrow?
That is the question.
If a resident radiologist in the year 2040 can never physically see the 0.58% fibrotic changes the machine relies on, do they eventually just become an administrator for the software?
And taking it a step further, we saw how the AI found that preclinical fibrosis on a routine trauma scan.
This 79-year-old woman.
Yes. As this technology becomes standard, we will inevitably start finding ticking time bombs in millions of healthy people's incidental scans.
Years before they ever feel a cough.
So the question is, in the age of AI imaging, do we lose our right to not know our medical destiny? Or is mining every routine scan for our future health risks the ultimate form of preventative medicine? Does the uniquely human art of diagnostics eventually fade away, replaced entirely by algorithmic certainty?
Or does the role of the human doctor simply evolve into something we can't quite imagine yet?
It is a massive frontier for the future of medicine and human expertise. Thank you for joining us as we unpacked it on this deep dive into the source material. Remember to keep questioning the world around you, and we will catch you next time.